If you would like to claim continuing education credit for attending today's session, register with CDC's Training and Continuing Education online system and search the course number on the screen for the Hospital Sepsis Program Core Elements webinar series.
Thank you for joining us for the fourth episode of our 5-part Hospital Sepsis Program Core Elements webinar series. Before we get started today, I have 3 disclosure slides to show related to the CE that's being offered through CDC's Training and Continuing Education online system. I will advance through them slowly to allow you time to read. The first is the following accreditation statement. This webinar is accredited for CME, CNE, CEU, CHES, MCHES, CPE, and CPH. I will now share with you the following disclosure statement from CDC. CDC, our planners and presenters, wish to disclose they have no financial relationship with ineligible companies, with the exception of Dr. Erica Kaufman-West, and she wishes to disclose that within the last 24 months, she was on the Speakers Bureau for Gilead and AbbVie for hepatitis C. All relevant financial relationships listed for these individuals have been mitigated, as she has divested the financial relationship. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from any ineligible company for this continuing education activity. I will now share the following joint accreditation statement for pharmacy education. And now, it's my pleasure to welcome you to the Centers for Disease Control and Prevention's Project First Line Hospital Sepsis Program Core Elements webinar series. Each of these 7 core elements provide essential information for facilities to use as they build and expand upon their individual sepsis programs. They complement existing sepsis guidelines and help facilitate the implementation of guideline-recommended care practices at a wide variety of hospitals and healthcare systems in the United States. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. Many people know that sepsis is the body's extreme response to an infection, but many people don't know the toll sepsis takes on U.S. patients. The CDC estimates that about 1.7 million adults in the United States develop sepsis each year, with 350,000 of those patients dying. Sepsis programs have been associated with reductions in hospital mortality, length of stay, and healthcare costs. There are many facets that go into a successful sepsis program, and we've put together this informational series to look closely at 7 core elements that facilities can use to build robust sepsis programs. Each 1-hour webinar brings CDC experts to discuss key features of effective sepsis programs, along with real-world partners sharing strategies, examples, and best practices for successfully implementing 1 or more sepsis program core elements. Today, we present the 4th of 5 webinars, and we will focus on data. Tracking and reporting sepsis metrics help hospitals ensure their programs are meeting their needs and also that they are filling in gaps when identified. Our sepsis core element experts will first outline what these 2 core elements are and how management of data keeps clinicians engaged and striving to improve. Next, we will hear from 3 more experts sharing their personal experiences with defining and collecting data and sharing that data in meaningful ways. In addition, our sepsis experts will be answering your questions live, both during the discussion portion of this webinar and via the Q&A chat panel on your screen. We will try to answer each of them, but unfortunately may run short of time to address them all. Also, if the slides appear blurry on your screen, please increase your screen's resolution by clicking on the bars in the bottom right of the video player and selecting a higher quality setting. Now, I'd like to introduce our first speaker. Dr. Hallie Prescott is an associate professor of internal medicine at the University of Michigan and a physician at the Ann Arbor Veterans Affairs Healthcare System. She is an internationally recognized expert in sepsis management and outcomes. She serves as the co-chair of the Surviving Sepsis Campaign Guidelines and physician lead for the Michigan Hospital Medicine Safety Consortium's Sepsis Initiative. She will discuss 2 core elements, tracking and reporting, and how defining and using data can augment the work of a sepsis program. Dr. Prescott.
Great. Thanks so much, Dr. Kaufman-West. It's my pleasure today to be giving a high-level overview of the CDC Hospital Sepsis Program core elements and to introduce the 2 core elements of focus today, tracking and reporting. I'll pause here and give people a moment to read the disclosures. This slide shows high-level results from a recent morbidity and mortality weekly report discussing the current state of U.S. hospital sepsis programs. So from the 2022 NHSN annual survey, with over 5,000 U.S. hospitals reporting, we learned that currently 73% of hospitals have a sepsis program or a sepsis committee in existence. When we dig a little bit deeper, we find that there are opportunities to further strengthen these programs. So, for example, we found that only 55% of hospitals provide any sort of dedicated time for the sepsis program leader or leaders. So essentially, these are, additional sort of activities that are sort of tasked on already busy people. And it's important that there be sort of dedicated time to manage and lead the hospital sepsis program. So we think that that is one example of a key opportunity to further strengthen U.S. hospital sepsis programs. Another example is that only 55% of hospital sepsis programs have any involvement of antibiotic stewardship representatives. So there's sort of poor connections or lack of connection between hospital sepsis activities and stewardship activities, even though those are sort of interrelated. And so there is an opportunity to further strengthen programs by improving the multidisciplinary involvement in these committees. Next slide. So the purpose of the hospital sepsis program core elements is really to provide a high-level guidance, a manager's guide for how to develop a program to monitor and optimize the hospital management and outcomes of sepsis, essentially how to build a successful program for doing these things. Key areas of emphasis include having hospital leadership support, having the necessary personnel involved in the program, and then using quality improvement tools and implementation science techniques to evaluate interventions that are developed to ensure that they are maximally effective. The hospital sepsis program core elements are meant to complement existing sepsis guidelines and facilitate implementation of recommended evidence-based practices. A key sort of thing to note about the hospital sepsis program core elements is that they cover management throughout the course of hospitalization and preparing patients for recovery. So in sort of prior initiatives, there's been really a lot of focus on early recognition and management, and those are critically important and are a focus of the hospital sepsis program core elements. But there is also a broader focus on ongoing management and recovery-based practices. This guidance is intended to be applicable to all U.S. hospitals and hospital systems. And so we've been mindful to try to build in flexibility, recognizing that a one-size-fits-all approach is not going to work for all 5,000 plus hospitals across the U.S., and that this is going to look a little bit different depending on the sort of setting and context. Regardless, this guidance should be applicable and should be able to be tailored to the specific hospital and population. So the hospital sepsis program core elements was released in August, and there was a number of different documents released. So first, the core elements guidance, which describes in more detail each of the 7 core elements. There is a hospital self-assessment tool that's included in the back, and that is essentially the place to start with this. It allows hospitals to go through and evaluate the current state to identify areas for focus in terms of building or further strengthening the hospital sepsis program. And then there are also infographics to provide a high-level summary of the 7 core elements. So I'll now walk through the 7 core elements. The first is hospital leadership commitment, and this really focuses on the importance of having engagement from high-level hospital leadership and having hospital leadership recognize and announce to the entire hospital or system that sepsis is an institutional priority. The second core element is accountability, and this has 2 pieces to it. The first is identifying a single leader or 2 co-leaders who are responsible for overseeing the hospital sepsis program. And the second piece of accountability is setting concrete sort of stretch goals for the hospital sepsis program, and then evaluating those on a regular basis, such as every 1 to 2 years, to see how the program is achieving these goals and setting new goals with an eye towards continual improvement and sort of further pushing the needle in terms of sepsis management and outcomes. Multi-professional expertise speaks to the sort of multidisciplinary nature in sepsis and the importance of involving stakeholders from throughout the hospital, recognizing that sepsis can often present in the emergency department, but also the wards and the intensive care units, and that there's a whole number of different sort of clinical specialties and healthcare professionals who are all really important to bring to the table as your hospital addresses sepsis. Action is a very sort of large core element, and that really speaks to having the structures and processes in place to implement best practices for sepsis. So this includes things like having institutional guidelines, order sets, care pathways, all the things to make it sort of as easy as possible to do the right thing for our patients. The next 2 elements go hand in hand and are the focus of today's webinar, and those are tracking and reporting. And this really speaks to monitoring sepsis epidemiology, management, and outcomes, and reporting that data back to the relevant stakeholders in a way that is able to further drive change. The final core element will be the focus of our next webinar, and that is education, and speaks broadly to education of healthcare workers, as well as patients, families, and caregivers. So on this next slide, I'll go into more detail about the tracking and then the reporting core elements. So for each of the core elements in the guidance, we provide concrete examples, and these are split out into priority examples and additional examples. So the priority examples are meant to be the place to start, and then as you're working to further strengthen, you can incorporate the additional examples. So priority examples for tracking of sepsis, including monitoring of sepsis epidemiology. How many hospitalizations are you having for sepsis? How many people are coming in with community onset sepsis? And how many people are developing sepsis during the course of hospitalization? Monitoring sepsis management. Again, no one hospital is going to be able to track everything. And so you'll need to think about strategically selecting the areas of management that you think represent the biggest opportunity or are areas of focus for your hospital sepsis program goals. Next is monitoring sepsis outcomes. And again, there's a lot of different outcomes of importance in terms of in-hospital mortality, hospital readmissions, patient-centered outcomes after discharge. And again, I think that selecting of which outcomes to measure really needs to tie in to what your hospital has identified as key gaps and key areas of focus in terms of your hospital sepsis program. The next is assessing the usability, and impact of hospital sepsis tools to inform their ongoing improvement. So this is really key. So as hospitals roll out initiatives, roll out guidelines, roll out order sets, roll out documentation templates, it's really important to then go back and evaluate, are these being used? Is there something we could do to tweak these to make these even more usable, to further sort of maximize their impact on sepsis management and outcomes? So it's key to essentially have some mechanism in place to evaluate the effect and impact of your initiatives. And then finally, monitoring progress towards achieving hospital goals for sepsis management and outcomes. Next slide. Additional elements for tracking include real-time chart review for the purposes of feedback to clinicians and educations. And this can be both constructive feedback, so areas where care sort of lagged, there were gaps in care, providing timely feedback directly to those clinicians. But then on the flip side, also providing timely sort of kudos, feedback to clinicians to say, oh, this patient came in, they got all the recommended sepsis, management aspects in a timely fashion, good job. This can be really helpful to driving engagement of clinicians to have this kind of targeted and real-time feedback, and really helpful for sort of, driving improvement when sort of both constructive and positive feedback is given. Chart reviews can also be helpful for the purposes of root cause analysis and process improvement. So this does not have to be done sort of real time or near real time. This could be sort of selecting a certain number of cases per month or per quarter that experienced a poor outcome, and sort of really digging in to say, was there something that could have been done that might have changed this outcome? So this can be helpful for sort of identifying potential opportunities for improvement going forward. Next slide. So for tracking, in the core elements guidance, we provide this table that shows example of different tracking metrics for epidemiology, management, and outcomes. And I've just showed the first portion of this table, but it goes on for several pages. And again, this is not meant to be that every single hospital needs to measure every single one of these things, but rather we give a large number of examples so you can go through and sort of select ones that you think are going to be most important for your hospital or your context, or to help facilitate the specific goals that your hospital sepsis program has set. So the next core element, again, going hand in hand, is reporting. So, we collect this data, we track these measures, but it's really important to get that data back out to the, people, the sort of frontline clinicians and sort of managers in the hospital. So the priority example for this core element is to report sepsis management and outcome data to nursing, physician, unit-based and hospital-based leadership at routine intervals, such as monthly or quarterly. And we think that there are certain aspects of that data presentation that can make it more impactful. And that is including sort of more local data, meaning at the unit level, providing trends over time, and then providing comparative or benchmarking data. And that could take different forms. That could be, comparing different units within an individual hospital, different hospitals within the same hospital system, or, your hospital versus other hospitals in a geographic area, or some kind of like other, sort of benchmarking norm data. In terms of additional examples for reporting, again, feedback to individual clinicians, like we mentioned, this requires more resources, but again, can also be very helpful in terms of driving change and driving engagement. And then having a live dashboard, again, also requires more resources, but allows clinicians and managers of the program to sort of go in and see sort of day to day, or sometimes even sort of interact with the dashboard to, have some flexibility in terms of how they view the data or how they interact with the data, which can be helpful. And I think that is my last slide. So I will pass it back up to Dr. Kaufman-West. Thank you.
Thanks, Dr. Prescott. Thanks for giving the high-level overview of all the core elements, and then also drilling down into the role data plays in a successful sepsis program. Now let's turn to some practical examples of how a couple of experts utilize data collection and reporting in their own facilities. Our panelists today are Ms. Carol Ann Gelderman, Ms. Michelle Evans, and Dr. Nima Sarani. Carol Ann Gelderman is the nurse manager for Northeast Georgia Health System Sepsis Program. Carol Ann has worked there for 20 years in various roles. In the past, she was part of the Cancer Clinical Trials Team, Quality Improvement and Safety Team, and led sepsis work as a coordinator from 2016 until 2020, when she expanded the sepsis program from a coordinator to a sepsis team. Carol Ann, can you share your experience with data tracking in your sepsis program?
Yes, I'd love the opportunity, and I appreciate being able to come and talk to you about what we've done at Northeast Georgia health system. Just a little background information. You can see here that our system does comprise an acute care with 5 campuses. We do have pre-hospital ambulatory settings. We also have post-acute care with long-term care facilities, rehabilitation, as well as transitional care and skilled nursing. Just to give you a little idea about how, what is our volume, we have about 500 sepsis patients across our 5 campuses per month. So that just gives you a little background. Our program is set up a little bit differently, as you mentioned when introducing me. This does show our kind of interdisciplinary factor that goes into our sepsis program. There are 3 key things that I wanted to point out. We do have a sepsis core team, which really is responsible for program development and program oversight. This is kind of the committee that a lot of people might have a sepsis committee, but we call it our sepsis core team. It is interdisciplinary, and we do meet and we do a lot of the reporting and tracking through this entity, but the biggest thing we do is program development. Our CMS abstraction is new to our sepsis department just in the last month. This actually was owned by accreditation and quality in our organization, but they were not set up to really do the improvement work, and we aligned them in October so that we could use our sepsis department and our sepsis team to align that improvement work. And then our sepsis alert team is really a team of individuals. We do cover concurrent review, so that chart review that was mentioned earlier as one of the additional things that could be done. And so we are providing real feedback to providers and nurses in real time based on a risk score. So I won't get into all the details there, but just know that we do have a team that covers 24/7. I really wanted to concentrate today and talk a little bit more. We do follow the traditional metrics, our mortality, our core compliance, but I really wanted to talk about other considerations for program success, some of the things that have allowed us to kind of prosper and gain that leadership alignment that you mentioned earlier. So there are kind of 4 points I want to show you with our data and our metrics today and our tracking. And one is making sure that we always have the patient at the center of that and connect the team members to that patient. I think is probably the most important thing. Aligning the process or outcome metrics to your organizational strategic plan also helps with that alignment with leadership buy-in. And then that actionable data, instead of just reporting data, really having that data something they can look at and then provide some action for improvement at the level of the patient, so at the bedside. And then to have some of your metrics readily available, so kind of that live dashboard that was mentioned earlier today. So I'm just going to show you a couple of these examples. But again, this is in addition to the traditional. What I'm sharing here is really just talking about aligning this with the patient in the center. So when we report up to our leadership, our unit level, and our core team, we talk about the number of lives. So these are actually patient lives touched by our concurrent team. So if we make a recommendation for a care gap or a gap in identification, or just an improvement for that patient's workup or treatment, then we would note that, and we share that on a monthly basis so they can see the impact of how many patients each month we're making recommendations on. So you can see in this short period of time, over 5,000, almost 6,000 patients were touched. The picture you see graphic on the right-hand side is really more of connecting our team, our sepsis team, and really now it's become organizational wide. They always want to see our VACE to the patient. So when we made a treatment recommendation, that was followed, and it changed the patient's treatment or their workup, we would put their initials on a stone and put it in a vase, and that's right in our sepsis office. So we could see that growing day by day, month by month. And like I said, it became kind of our, it identified us, our team. And so when we go present to senior leadership, they want to know about, how big is that stone, the vase? And so we have to move on to other vases. It's just a way to connect our team to that that's a real patient. and our organization to these are patient lives. It's not just compliance to a metric, but it's patient lives. So again, touching and making sure it's patient-centered care when you're reporting the metrics is always a great thing. Really, the reason we were successful in going from having a coordinator to a system that had a department with concurrent review around the clock was that we aligned with our organizational strategy. So we knew what the strategic plan was for our organization, and we made sure our metrics aligned to that so we could speak the same language. This is extremely important, especially if your department or your sepsis program is not a revenue generating, which I think most are not. You have to show a return on investment or a cost savings. So this is just one example. We did average length of stay because throughput was a big deal for our organization. We're always in census overload. And so, making beds available by treating the patients correctly and them not being in our organization as long frees up beds for the next patient. So you can see from our baseline to our post navigation, real-time concurrent review, we did shrink that average length of stay for our sepsis patients. You can see there just a dollar amount, which is savings per sepsis case. And I will remind you that we have about 500 sepsis patients in our organization each month in our acute care facilities. So this has meant millions of dollars of savings for our organization. And so when I present to senior leadership, that's the message that I talk about. It's about the patient, and also it's about the organization and the cost savings from doing this. So again, alignment with the strategies will help with that leadership buy-in that was so important and talked about in an earlier webinar. Having the data actionable and readily available, I think the idea of dashboard development, this is just an example of one of our initiatives. We have an EMS sepsis alert, and we created a dashboard. You can't see the functionality of it because you're just seeing a screenshot of it, but these are the things that were important for our dispatch at EMS as well as our sepsis team in our organization and our emergency department. We wanted to know how accurate our alert was based on what we're using for screening. So you see alert accuracy is there. We wanted to see the door to antibiotic time. And we were really shooting for being under 180 minutes. Our baseline was much higher than that. Almost immediately after implementation, that went down because, again, we had that concurrent team that would receive an alert before the patient ever came through our doors. And that way they could help with the ED to make sure all the resources were at the bedside when the patient arrived. The time saved for our sepsis alert team is one that is really just important to our team. And that is our alert through the pre-hospital alert came about on average 444 minutes earlier than our traditional alert when you're basing it off data from the acute care encounter. But the most important piece is over here on the left. We've built metrics and filters over here so anyone has access to this dashboard and they can go in and they can look at the data based on the month, on the quarter, the day of the week, on the campus, on if it was activated by dispatch or EMS. So again, it makes it real time for them. They can go in and see today that we had this many alerts yesterday. So again, it makes it a little more actionable. You're not getting the data so late. Another piece that we're trying, and this is fairly new to us just because we have taken over the core compliance beginning in October, but we started doing this work really back in the summer in July. But giving actionable data on a cadence that is really something they can take and make improvement rapidly. So this is just an example of a report to one of our campuses that we do on a weekly basis from our concurrent reviews. So they can see the weekly as well as monthly totals. I will tell you this is fake data that's in here because as you see from the bottom, we do show their failures and we also attribute that to a provider or nurse depending on which one it would fall to, as well as if it's an ancillary department, because occasionally we might have a lab or a pharmacy or maybe even respiratory input into that failure. And this is provided on a weekly basis. So really, if you're looking at it today, then I can make that change for this next week, and I can make a change in that month from our compliance. So again, very actionable, getting the results, being able to see them at a very quick cadence makes all the difference. So I hope I kind of hit each one of these, but again, to just summarize, aligning the process and outcome metrics to the organizational strategies will help with that buy-in that's really needed for a sepsis program. Keeping the patient at the center and making sure the team is connected to that patient. It's not just tasks they're doing. And making sure those process or outcome metrics are readily available and actionable and given in a quick amount of time really helps with program success.
Thanks, Caroline. I appreciate you sharing your experience with us and making it so focused on the patient, that patient-centered approach. And the visual of the vase is wonderful. Thank you for sharing that. Next, we have Michelle Evans. Michelle obtained her ADN in 1999 and BSN in 2007, both from Walsh University. She earned her master's as an advanced practice nurse in 2010 from Malone University and is board certified through ACE-NCC as a family nurse practitioner. Her clinical background is critical care, rapid response, and hospitalist medicine. She carried her CCRN certification through the AACN from 2005 to 2017 and is Fundamentals of Critical Care Support trained through the Society of Critical Care Medicine. Michelle discovered her passion for sepsis care while serving as the intensivist program coordinator for Altman Hospital from 2002 to 2009. She is currently employed at Summa Health System as the sepsis program coordinator, a newly created program and role in January 2021. Michelle, how have you used data tracking and reporting to improve your sepsis program?
Well, thank you very much. So as mentioned, we are a newer program. So our program was started in 2021 after they identified some need for us to really focus. So as far as Summa Health goes, we're a moderate-sized system. We have two main campuses in Akron and Barberton, and we see between the two about 150 or so cases per month between campuses. Next slide. Tracking sepsis care was pretty fragmented before I got here, and everybody had kind of irons in the fire and they wore many hats. So we felt the need to really focus in on sepsis because it is such a serious DRG and does affect a lot of the cost and mortality rates. So I was hired in as the dedicated coordinator in 2021. At that time, we only had CMS recorded abstractions. So I started a concurrent review of any chart that I could get my hands on. And I kind of didn't have a smooth process at that time, but I have an amazing analytics team. So we worked together to create data reports that I could pull from the EHR and kind of weed out the patients. So I started with determining where we were, and that's very important. And even though this does take up a lot of my time, probably 2 to 4 hours a day, I'm going through anywhere from 80 to 100 charts a month, if not more, to try to find the compliance. I do feel that this is one of the most important parts of my job because you don't know what you're missing or what you're failing on if you're not really following that closely. So I really try to keep my finger on the pulse of our compliance. So once I determined where we were with compliance, I looked through deficiencies, what we were missing, what we needed to focus on. And then there was a lot of background work that was done before we really got started. We went through the med staff office and came up with an approved sepsis definition and diagnosis to what we would expect our providers, how they would identify sepsis, how they would document it, diagnose it and treat it, so that we had a standard plan. And we do go by the SEP1 metrics that CMS has as their core measures. So we had our official kickoff in March of 2021, and that is where we did a big education in the EDs and really focused on care and identification, and we started to see a turnaround on our compliance. One of the, I think, greatest and most helpful things that I did was find physician champions. So I have several wonderful physician champions. I have one for ED, 2 for ICU, and then we have a residency and inpatient physician also. They helped us come up with a dot phrase that would work for them. So we do, it's not an official requirement, but it is strongly suggested that they use this. And then our data analytics team was also able to come up with a database for me. So I have this homegrown database that I am able to enter all of my chart reviews into myself. This is separate from what the Premier abstractors use. So we have 2 abstractors employed by SUMA that will abstract charts that are sent to us through Premier, which is our provider for CMS compliance. So while they probably report out an average of 9 cases per month that actually are selected, I'm able to report out up to 90, as I said. And then it's really important that when they get a fallout, they send that back to me so that I can review it, and then we concur. So there are times that I found that it was off and that it really did not fall out. So we were able to save on that. So that has been very helpful. And then, of course, reviewing the Ohio Hospital Association data has been huge. Next slide, please. This is an example of our core measure phrase. We try to make it all one-stop shopping. So they have everything in here that they need, both for the abstractors to see what their thought process is, such as the sepsis time, and then also rationale, such as why they didn't give enough fluid. The reassessment exam, pieces that we really need for our documentation piece that we're falling out. They were doing the protocol perfectly, but then they wouldn't document appropriately, so we would be falling out on that. This really helps with tracking, and we are up to about 90% compliance with use of this form. So when we see a sepsis diagnosis, our ED has been amazing at using this. They're about 90%, and our inpatient side is now coming onto our side, and they're using it much more. So it's been really helpful in our documentation piece. Next slide, please. So as far as our reporting goes, we do report system-wide now, where prior it was very fragmented. We take our data and report it out to multiple committees. We have a sepsis committee that meets monthly. It is a highly multidisciplinary committee. We also report our data out to ED, ICU, hospitalists, and maternity. Our maternity team just joined us this year and honestly did an amazing job of revamping their order sets. And they also have a core measure phrase and did a real push for education. So these little departments that kind of came out of the committee and have really taken ownership for sepsis in their department has been very helpful. And then we also report to quality and leadership teams also. We do really use our data to identify areas of focus and to drive the projects that we come up with. Next slide, please. We do report to the staff. That's also very important. As Dr. Prescott said, really letting the staff know the feedback is very important, because you can't fix, again, what you don't know. So I send out emails concurrently. I try to do my reviews within 24 hours other than the weekends. Sometimes they'll get an email back within 8 to 12 hours of seeing that patient so that they know right away. And I'm all for positive. So we have our providers who will say, "Oh, I got a negative email. I hate those. I don't want to do anything untoward for my patients." So they don't like getting those, but they love the positives. And then also reporting out in our ED huddles. We have huddles every day, twice a day, and we report feedback out to them, what our fallouts have been, what our focus is, and then also how well they've been doing. And then I think recognition is huge. Recognizing people in the CNO weekly newsletter. We'll send out our sepsis super nurses that we send out. And then we just created an award. These are our award winners this year. So this is our second annual award. And we recognize a department, which is our maternity department. And then we pick 3 individuals who have really been standouts in driving sepsis improvement here at SUMA. Next slide. This is our bundle compliance over time. So as I said, we're a newer program. I feel like we've made a huge impact in such a short amount of time. So pre-program, we were looking at 44% core compliance, and we've been hanging in the 70s. And here recently, we've even been hitting the high 80s. So our goal is 80 or above. So we're really starting to reach our goal. Next slide, please. I do keep track of our fallouts. So these are our fallouts in general. These are what's reported out to staff. For example, the blood culture was identified that the problem is that the nurses are just scanning their labels after the fact. So they're doing the blood cultures, they're doing the antibiotics, and then scanning. So we were able to kind of really whittle down on what the problem is. And our big focus right now that we've kind of fixed. These other things are the antibiotic timing. Next slide, please. This is an example of how we follow our antibiotics. So this is a project we're working on now. We are trying to determine where our fallouts are and what our greatest opportunities are. And we're really focusing on septic shock and trying to get those antibiotics in and within an hour for our shock patients. Next slide. This is an example of our weekly ED sepsis report card, like many of you have shown. We will highlight the fallouts and share with staff and talk with staff and kind of let them know what the fallouts are and where the areas for improvement are. So out of this, we have noticed an increase, for example, this month of nursing fallouts. So we focus in on those and try to turn that around and find out what is going on behind the scenes that's causing the fallouts. Next slide. I think this is the most important thing because the biggest thing isn't the numbers and how pretty they are. This is the mortality. So since we've started the program, we've seen us fall below the Ohio rate. And most excitedly, this past quarter 2023, we've seen ourselves fall below not just Ohio rate, but Ohio goal. So that's very rewarding. When we share this with staff, I think that's when they get the most excited because they're sending their patients home. And next slide is also Barberton. So their rates have been well below also. So for me, this is the most exciting part because we are able to show that we're not just telling you to do something, but we're actually making a big difference. So that is all I have. I do have some reference materials, I think, that we have at the end for you that are showing some of the things that I talked about in this presentation. And thank you for letting me share with you.
Thank you, Michelle, and congratulations on those amazing mortality rates. So great job for you and all your help over there. I'm happy to introduce our last speaker now, Dr. Nima Sarani. Dr. Sarani is an assistant professor of emergency medicine and assistant director of operations for sepsis care at the University of Kansas Health System Emergency Department, where the ED CMS SEP1 compliance average is over 90%. The improved SEP1 compliance was achieved through ED sepsis initiatives, which have resulted in decreased sepsis mortality and cost indices. Dr. Sarani, can you explain how you use data within your sepsis program?
Absolutely. Thank you so much for the introductions. So just the basis as far as our department, we're a level 1 trauma center in the main metro Kansas City area. We see approximately 70,000 ED patients annually. It's pretty high acuity emergency department with 36% ED admission rate. About monthly average of 300 septic patients are in our health system. 208 on average septic patients are admitted through the emergency department. And of those patients, 190 on average have sepsis present on admission. Next slide. So this is just to demonstrate our trend in CMS performance. You can see since the ED Sepsis Initiative that was implemented in October 2020, our CMS compliance has significantly increased from the pre-phase into the post-phase, and the red line is basically a national average. So we currently maintain a performance level way above the national average. Next slide. We've done this through honing in on three important, we call it 3 pillars. One is educating all of our providers regarding our sepsis initiative. This includes nursing staff, APPs, residents, and physicians. And then we hone in on the communication piece, which specifically looks at the communication within the primary team that's taking care of the patient at bedside. And then we go through an intense review process of our sepsis patients, which I will get into more details on that. Next slide. So we select approximately 25 sepsis patients per month. These are randomly selected. Gets reviewed by our sepsis outcome coordinators, and either fallouts or passing of the metrics are noted. Regarding the fallouts, it gets discussed with the sepsis liaison, the ED sepsis liaison, which is me. We go through the case and then involve the primary team that was taking care of the patient. We discuss, some of the things that occurred during the case and some of the things that could be done better, identify specifically what caused the fallout, kind of understanding some of the lessons learned per case. goes back to the sepsis outcome coordinator. If there are additional points of clarification needed, the sepsis outcome coordinator is in touch with CMS, and they can directly propose the questions to them for additional clarification. Once that's made, the monthly sepsis cases are finalized, both cases that are passed and the cases that have fall out. And both of those scenarios are sent out to the primary team and the sepsis stakeholder. So not only you receive the fallouts, but also receive the ones that have passed all the metrics. So more of a kudos, kind of an email to the individuals involved in that case. Next slide. On a monthly basis, we go through kind of detailed review of the specific fallouts that occurred during that month. This is just a sample slide of a slide that we presented to the staff during a staff meeting on one of the months. And it goes through specifically the case and what turned out and how the fallout occurred, and some of the things that we can do differently to avoid the fallout going forward. The point of this is to ensure that everyone else, all the other providers, are aware of the specific lessons that were learned per that particular fallout. And this basically gets reviewed and presented to the ED staff, which includes the APPs and attending physicians, as well, send out to the residents as well. We're a full-fledged academic hospital, so we have a lot of EM residents as well. All right, next slide. In addition to reviewing it during our staff meeting, we also have a monthly email that goes out to all the providers, again, including the residents. And this goes through our overall performance and talks about our CMS compliance. And then once again, we talk about the case that fell out. The case is sent out in a blinded fashion. It's a non-punitive, more of a constructive kind of feedback. Again, the point is to make sure that we can avoid the particular fallout moving forward. And then within this email, we also talk about sepsis index performance. We believe that it's important for all the providers to be aware of the overall index performance. And this particularly includes the mortality index for sepsis and also the cost index. Next slide. Of all the metrics, we understand that likely antibiotics is the most important one. So we do some additional review of the antibiotics. So overall, the sepsis cases that we reviewed is about 25 randomly selected sepsis cases. But in regards to antibiotics, we review every case that has an ICD-10 diagnosis of severe sepsis and septic shock. As you can see on the first column, the name of the provider is blinded, and every provider gets a number. We have the sepsis severity, a severe sepsis, septic shock, and then we determine some patient severity identifiers, such as the first lactate, first MAP, first blood pressure. And then we enter the time that the antibiotic was ordered, and then the time that the antibiotic was administered. We also determine time 0 to antibiotic order, which is the provider time, from time 0 to when they decide to order the antibiotic and they actually place the order. And then order to antibiotic time, which is a nursing time. It's from the time that the antibiotic was ordered until the time that it was actually administered. And then the final column to the right is time 0 to antibiotic administration, which is essentially tells us how we overall performed. Obviously, we want to keep that number less than 180 to ensure compliance with CMS. So this is important for providers, including nurses, to kind of go through and kind of look at their numbers on a monthly basis and see, for a patient that came in, time 0 was at a certain time, and then the order was made 3-4 hours later. What happened exactly in that scenario? And if needed, we can provide specific patient identifiers, and we can review the case with the team that was involved, go through the chart and try to figure out what was the reason for the delay administration of antibiotics. Next slide. I kind of touched on this. So on a monthly basis, we go through the overall CMS performance. In red, you can see our ED sepsis performance, which as you can see, there's been multiple months that we've had 100% compliance in the emergency department. And then the blue line shows our health system performance, as most of the patients that are septic come through the emergency department with improvement of our compliance in the ED. You can see that the health system's compliance is also increased from the pre-phase again to the post-phase. Next slide. We trend our mortality index, and we use Vizient. This is particularly looking at the O to E ratio, the observed versus expected mortality for sepsis patients. And this is the component of ED admits with sepsis present on admission. You can see observed mortality in lighter blue and the expected mortality in the darker blue. And we compare those to our cohorts, the top 10% academic medical centers in dotted line. And any area that we see a peak in the observed mortality and a decrease in the expected mortality, we hone in those months and try to figure out exactly what happened and why did our mortality index suffer. Next slide. This one essentially looks at the same thing. This is the mortality index, so the O to E ratio. The blue line at the bottom shows our ED sepsis patients, that sepsis is present on admission. You can see the O to E ratio or the mortality index there. What I want you to pay attention is the upper right-hand corner of the graph, where you can see in red, there's a very high mortality index. This is a particular component of our sepsis population. These are patients that come in through the emergency department, but sepsis is not present on admission, whether it was not diagnosed or potentially sepsis was developed into their hospital course. As you can see, the mortality index is pretty high in this patient population, and this is true across other hospitals as well. When we compare this component of our performance to other hospitals in the nation, we note that the mortality index in this particular component suffers. On the left-hand side in the dotted line, you can see the O to E ratio of this component. As you can see, the expected mortality, which is the darker red, the dotted darker red line, is always lower than the observed mortality, meaning more patients are dying than were expected to die from sepsis. So this is the problem component, not only within our hospital, but other health systems as well. Essentially hones in and suggests the occult sepsis population that have poor outcomes. Next slide. And lastly, we'll look at the cost index, and we monitor that on a monthly basis as well. The red arrow shows when our ED sepsis initiative was started. So this is the O to E ratio, specifically for the cost index. As you can see, our cost index has decreased, which means we are doing better as far as cost saving. Like mentioned before, these trends and these graphs, especially the indices, are important for the stakeholders, the board of directors, the hospital, to make sure they continue investing in our sepsis initiative. And that's it. Thank you.
Thanks, Dr. Sarani, and everybody for sharing those presentations and giving us some real world examples. I have some questions that I would like to get to from the audience. This first one is for Carol Ann from Barbara. What sepsis screening tool do you use at your facilities?
So we currently use the EPIC predictive model. So we had it validated. We're actually moving to version 2. Our EMS sepsis alert is actually based on the 3100s, which is a tool used by skilled nursing facilities. So depending on what initiative you talk about, we use different screening tools.
Thanks for that. Next, for Michelle, this was a question regarding your internal abstraction versus Premier. Do you feel that the 9 charts per month from Premier accurately represent compliance and areas of opportunity at your site when you compare them to the larger sample that you review yourself?
Yeah, so that's the problem. It's a luck of the draw. So we abstract the bare minimum. So they're given 20 cases per month, and out of those 20, they typically throw at least 50% out. So I have seen a big variance. Now, that being said, we've had a couple of months where they were 100% and I was 70%. So it goes either way. So I like I like my side, to be high. But yeah, that has been a problem. We're getting ready to do a research study regarding something else, and we're going to do 100% official abstraction. So we're going to be able to judge to truly see if it's reflective of what we're doing. But if you look at the CMS numbers, they don't look good. But it kind of is what it is.
Yes, we've all been there trying to, look at the big picture versus,
right.
those more narrow guidelines. A question for Dr. Serrani. You mentioned how antibiotics are a big marker for you when you do your data abstraction. This is a question. Are pharmacists in the antimicrobial stewardship program involved in the tracking and reporting effort at your organization? And if so, how?
So they are involved. We have a robust ED pharmacy in our department, which is one of the unique things that we have in our emergency department. But in regards to ordering an antibiotic for a patient, it always gets verified with our ED pharmacist to ensure, one, if there was previous cultures, if there's any questions why the antibiotic is even being ordered on this patient, they come and we have a one-to-one kind of conversation why we think antibiotic needs to be administered to this particular patient. In regards to all of our metrics review process, which includes the antibiotic as well, we've included all of our ED pharmacists on those communications as well, so they are kind of aware. And usually when we're in general, when we have a patient that's in the ED and we're suspecting infection, part of that communication piece is to make sure that not only your nurse but also the pharmacist is aware that this patient is potentially septic and your pre-test probability is high enough that you're going ahead for the antibiotic order. In those scenarios, the pharmacist is aware, okay, this is why I got to prioritize this order over the Tylenol for another patient to ensure this patient meets the metrics. I'm not sure if that answers the question, but they are involved, yes.
Great. How about if I go back to Carol Ann for this one? I remember you talked about looking at compliance and a lot of it focused on that dot phrase that you had. How do you differentiate ED compliance from inpatient compliance?
So our metrics that we share, we do filter out. So the ED is seeing their compliance and the inpatient units are seeing their compliance. So we just filter out those. And so really when we're presenting that, nursing sees all of them because we share the same nursing slides on a monthly basis at our staff meetings. But for providers, we have sections. So the ED, sees their results in their provider section meeting, and then hospital medicine will see the inpatient. If they're cardiology or trauma, they will also see that. So we just filter those out for the entity that needs to see it.
Got it. Back to Dr. Nema. How is sepsis POA defined at your facility?
So POA is a flag that we can include when we're searching for ICD-10 diagnoses. Most of these charts are coming from Vizient. That's where we're looking at these different components of our septic patients that are in our health system, whether they came through the emergency department, whether they were transferred. But POA is a flag that you can add on, and it's basically sepsis present on admission, meaning if that diagnosis was present in the ED note, ED provider's note, or in the H&P. Also, the other component of the present on admission that you should not forget is those patients that are transferred to the hospital and the sepsis is diagnosed upon presentation. So that's just a flag that you can add, and you can separate the two, present on admission versus not present on admission.
Great, thank you. I'll do one. We've got time for one more. Michelle, you struggle with determining time zero when you're doing your abstractions.
Absolutely. I think everybody does. It's very elusive, right? So what we do is we have our dot phrase, and to me, that's the time that the physicians feel that they actually have all the criteria met, meaning they may not have an infection yet. So I typically will use that time. However, I will go and make sure that they actually did meet criteria at that time. And then what we do with our official abstractors is they delineate time, and then if it falls out, they'll send it to me, and then we'll kind of concur to see if we agree with time zero. But typically, the dot phrase has been very useful, and we do find that when they put that time in there, that's generally the correct time, and that satisfies the piece where we're not sure we have an infection. Maybe they're meeting all that criteria, and then all of a sudden you get an X-ray back saying it's pneumonia. So if we don't have that dot phrase in there, we have to use the time they opened up the note, which is the time they rolled through the door, as an infection. But if I have my dot phrase in there and they put that time in there, then I'm able to use that as their actual time of infection. So that's been very helpful for us meeting the compliance, and then also kind of delineating time zero. But I wish we could make it easier.
Thanks for sharing that we all struggle with this.
For sure.
Thanks to everybody for the great discussion, for your wonderful presentations. So in summary, no program can measure everything, and only by prioritizing what to measure, focusing on the processes and outcomes that are most important to patients and anticipated to represent the greatest opportunity for improvement in the hospital, can sepsis program coordinators choose metrics to track. Some metrics include epidemiology, management and outcomes of sepsis. Usability and uptake of sepsis tools are another data point that facilities might find helpful. Reporting of sepsis management and outcomes to relevant staff can help maintain staff engagement, motivate behavior change, and facilitate improvement in these metrics. Transparency is key and clarity is essential. Leaders should be clear on definitions, what data was collected, and how measures were calculated, so that staff can see how their input and commitment changes these outcomes. There will be a recording of the webinar on this page shortly for you to review and share with colleagues. In addition, there's a resources tab in the top left corner above the video where we have collected helpful websites and links related to our discussion today, including a few that Michelle shared. For example, we had many requests in the last webinar for presenters' education guides and algorithms, so we recently uploaded those in that webinar's resources section. Thanks to our speakers and to you all for your continued commitment to reducing the morbidity and mortality associated with sepsis. We have covered 6 of the 7 core elements now, and we have a nearly formed picture of what a sepsis program requires to be successful. We also have a growing community of learners here to provide support as we embark on growing our individual sepsis programs. We are thrilled to announce the final webinar on December 7th at 1 p.m. Eastern Time. There we will discuss the 7th and final core element, education. As always, when you register, please ask questions so our experts can use them to inform the content of their presentations. We will also use them to foster our panel discussion, covering the information most relevant to you. Thank you again for your interest and attention. Have a great afternoon.